So I've titled this presentation, Bringing MAT to Residential Treatment. To change is hard, to not change is fatal. It's a little dramatic, but not so dramatic in the sense that we all know that deaths from opiate overdose are out of control. It's on the news every day. We're at an epidemic level, according to the CDC. More people died from overdoses last year than died in car accidents, which is pretty major. And just came out recently, over the last few weeks, that the life expectancy for some portions of our population, especially white women, is going down for the first time in many years. And those that have done the research on this attribute that to a combination of overdoses, tobacco, and heavy drinking. That pretty much falls in our category. And then the other main factor was suicide, which also falls into our category to some extent. So we have a lot of work to do. The other reason I chose the word fatal is in a much less important sense, but relevant, I think, to those in this room, which is that I think from a business point of view, MAT is becoming, I would say it already is, the standard of care. Medication-assisted treatment is what insurance companies are looking for if you want to get reimbursed for your services. And I think over time it's going to become more and more difficult to justify not providing access to medication-assisted treatment, which in my opinion is good. I also don't want to pretend that we should look to insurance companies to guide us as to how we should be treating patients. That's not necessarily a good thing. But I think anyone who's claiming to provide evidence-based treatment for substance use disorders has to have medication-assisted treatment as a part of what they do. So my presentation today is not to convince you that you should use medications as part of your treatment. I think there's a presentation after mine that will probably try and do that, another doc who's presenting on MAT. And I have other presentations on that, but I won't bore you with those today. So I'm not going to focus on that. I am lying a little bit. I'm going to show you some more recent data on MAT that I think is useful. But the majority of this talk is going to be on how do you bring MAT to residential treatment and get your whole team on board with doing it? Because that's not easy. Despite the fact that the evidence might be very strong, it's not easy to get everyone on board with it, and I'm sure there are many in this room who have many doubts about it still. So I'm going to address some of those and hopefully give you some tools for how to talk to both patients and your staff about how to go about it. Okay. Oh, this is my financial disclosure. I don't have any relevant financial things to disclose. I kind of wish I did, but I don't. So. I do work for Sunspire Health, and believe it or not, they do pay me, so that is one thing that you should know. So these are the objectives. We're going to talk about barriers to implementing MAT, both on a national level, a systems level, and then sort of individual providers and patients. And then some strategies on how to implement MAT, and talk about different factors that can help and hurt that process. So this is data. We don't have much data on how prevalent the use of medication-assisted treatment is. But what we do know is generally that about 30 to 50% of licensed addiction treatment facilities offer any of the 3 medications that are FDA approved for opiate use disorders. So that's methadone, Suboxone, and naltrexone or Vivitrol. Only 34% of facilities in the private sector, patients receive an FDA-approved medication during their stay in treatment. And only 24% of patients with an alcohol use disorder receive an FDA-approved medication. That one stands out to me particularly because I absolutely understand the controversy of Suboxone with opiate use disorders. There's a lot to say about that. But the use of things like antabuse and naltrexone for alcohol use disorders, that one surprises me, that there's such a low rate of use. There's very clear evidence that these are quite useful. So I told you I was going to review a little bit of evidence on MAT. I promise it won't be too long. This is a recent study, Dr. Weiss's group out of Harvard. This is the POAT study. So the prescription opiate addiction treatment study. This study is unique for a few reasons. One is that it's one of the few trials that looks specifically at prescription opiates. So there's not many trials that only focus on people addicted to prescription opiates, meaning not heroin. So it's unique in that sense. And this trial initially was done, I believe it was 2006 to 2009. And it was designed, again, to look at the prescription opiate users. What they did is they had all patients go through a 4-week Suboxone Taper. So put them on Suboxone, stabilize them, gradually tapered them off. The success rate for abstinence at 4 weeks after that was 7%. So 93% of people relapsed. So what they did is they took, and they randomized people to either a sort of standard medication management counseling versus some opiate relapse counseling. Didn't matter. Both relapsed at basically the same rate. So what they did after that is they took these same patients and they extended they put them back on buprenorphine, extended it for 12 weeks, and then measured how they did over those 12 weeks. And it turns out that 49% of patients were abstinent from other opiates at the end of the 12 weeks. So this is one of the main studies, although there are many others, that supporting the use of Suboxone for longer periods. So the researchers then, Dr. Weiss's group, then wanted to see, well, how do they do long term, right? So they went back, and this took a while because they had to go back and get IRB approval, and so they ended up checking again at 18 months for a lot of these patients after the 12-week trial. And I'm not going to go through all the details of it, but essentially, let's see, we'll move on here. So they got in touch with about 57% of the study participants, and they followed them up at 18, 30, and 42 months. So that's a pretty good longitudinal study, and actually one of the few that we have. At 42 months, 31.7% of patients who have participated in the extended Suboxone Taper, so that 12 weeks after the initial relapse, they were abstinent from any opiates, including Suboxone. So these are patients who went through the 12 weeks, then got off of Suboxone, and remained abstinent. So that's pretty good. I mean, certainly better than 7%, right? And so this suggests that a longer taper of Suboxone, which is, again, this is supported in many other studies, might be quite useful, and it's sort of encouraging that a third, basically, of patients were able to stay off of everything. Another 30%, 29.4%, were still on Suboxone, but they were abstinent from any other opiate. So they didn't meet criteria for an opiate use disorder at that point. 7.5% were using other opiates while on Suboxone. This is the group that we all know and love, right? This is the worry with Suboxone. I have it too. And then about a third had relapsed and were still using actively. So what's significant about this, I think, is that 61% of the patients in this group no longer met criteria for an opiate use disorder. That's pretty good. 61% recovery rate at, 3.5, no, is my math right? A little less. 3.5 years, that's pretty good. It's actually and that 60% stood out to me because that's roughly the same percentage that we get in other chronic illnesses in terms of stabilization. So diabetes, high blood pressure, asthma, that's about the control rate that we get in other chronic diseases. So to me, that suggests that we really are dealing with a chronic illness here. They're very difficult to maintain, and we're never going to get to 100%. And 60% is a pretty good threshold. So, okay, so that was a brief digression, but I think it's important because it suggests that when we think of Suboxone and other medication-assisted treatments, it often is the thought is, well then, how do you get off of them? Like, will they ever be able to get off of them? This study seems to indicate that actually you can. Now some don't, obviously, but 31% of that population did and are doing well. So what are some national barriers to bringing medication-assisted treatment to residential treatment? This is a huge one. Speaking as someone who's gone through medical school and residency, when I talk to primary care docs that are friends of mine now, and I ask them, do you treat addiction? It's always like, no. I said, well, have you ever thought of getting like a buprenorphine license? Ugh, no, I don't want to deal with those people. And when I talk to them about it, it's fascinating to me because it's the same biases that exist in the general public exist among my medical colleagues, which is kind of sad. Patients are too difficult, they lie, they don't show up for things, they, misuse other things and don't tell me, all that stuff, right? There's a couple of things that always fascinate me about this, because then I'll usually ask them, well, how about your diabetic patients? How well do they do? Oh, I hate those diabetic patients. They're horrible. They don't take their insulin. They come in with, toe infections, and I said, oh, well, so do you not treat diabetics? Oh, no, I treat them. Okay. Again, chronic illness, not easy. What I think, and then there's been some research on this too, a lot of the reason for this is that in med school and residency, the exposure to addictive disorders, to substance use disorders, is largely in the worst case scenarios. So when I was in medical school and residency, the exposure I got was in the ER, where people are either withdrawing like crazy or med seeking. In the inpatient hospital where people had severe life-threatening withdrawal from alcohol or benzodiazepines, or in fulminant liver failure. So what I was seeing was these were the severe cases. These were the, in some ways, end-stage cases, right? I wasn't seeing the whole spectrum of people. So it's not so surprising that when med students and residents get out of residency in internal medicine, family medicine, things like that, they don't want to treat people who are going to die. That's not what doctors go into medicine for usually. It's a part of what we do, but we don't like it to be the only thing we do. Even oncologists don't like that. So, but if you think about in terms of heart disease, diabetes, things like that, med students and residents see the whole spectrum. They see people who come in with a new diagnosis of diabetes and they become very compliant with diet and exercise or maybe insulin and they get better. Same with heart disease. But they don't really see that because a lot of our addiction treatment doesn't happen in the hospital, and in general most academic institutions don't have great outpatient addiction treatment, as most of you all know. So there's a real bias there, and that's a problem. So we really don't have enough physicians, as I'm sure most in this room can attest to, that can do it well. We have a bigger number of docs who don't do it well. And then there's governmental restrictions on methadone, obviously, and then I already kind of talked about buprenorphine. The other thing about buprenorphine that's fascinating is I never understand the irony of I can prescribe as much oxycodone as I want. I could throw it out, I just throw it at patients and it would be totally fine. If I prescribe buprenorphine and have it in my office, I am likely to get a DEA agent showing up and raiding my office to make sure that I have it properly documented. It's really bizarre, and it really does, especially for primary care docs. Well, why would they want that trouble? Why would they want a DEA agent showing up at their office, right? So they just keep prescribing OxyContin. I'm gonna beat on insurance companies for a little bit, and they're an easy target. What I will say about insurance companies that I appreciate is that they really are driving this conversation about medication-assisted treatment because they're requiring it in most cases to get reimbursed. And so I appreciate them for that. Now, their motivations for doing that we could talk about, but in any case, the things I've seen, and I'm sure you all have other stories, some insurance companies only cover one of the approved pharmacotherapies. It's usually Suboxone and not Vivitrol or naltrexone. They limit doses that don't correspond to clinically recommended doses. So often with Suboxone, they'll say, well, you can't give them any more than 12. Which again, I've never heard of a limitation on OxyContin or on insulin. There are lifetime limits. Again, I've never heard of a lifetime limit on insulin, or OxyContin for that matter, unfortunately. Prior authorization, all of you probably have enjoyed this process. Prior authorization that I've got a patient on buprenorphine who's been doing well, and their PA comes up, and it has to go to medical review. Well, the patient's going to run out in 3 days. Well, our doc's gone, exposing the patient to relapse and potential death. But prescription refill limitations, again, for a chronic disease, does that make any sense? No, this one is probably the one that bothers me the most. No or minimal coverage for counseling, other behavioral therapies, despite very clear evidence that combination with medication has superior outcomes. I mean, and fail first criteria, so, well, this person's overdosed on an opiate, almost died, but they've never been to treatment before. So let's send them to outpatient treatment near their home so we can see if they try again, instead of sending them to a more structured setting, like we would do with any other illness, by the way. If someone with diabetes showed up with diabetic ketoacidosis, you wouldn't say, oh, well, they should start with their primary care doc and get that stabilized because they've never been in treatment before. No, you put them in the ICU and you fix them up. And then the favorite of my staff at all of our sites is the excessive demands for treatment notes, attendance records, et cetera. So some systems level barriers at the individual clinic or wherever you're working is sort of an emphasis or exclusive 12-step model. And this is not to say that 12-step and MAT are in any way not able to be merged. That's what we do at Sunspire. This is language from a particular study that's cited down here. What they mean, of course, is that where abstinence, meaning no medications at all, is the only possible option. That's what it's referring to. Suboptimal dosing levels is especially due with Suboxone. Docs will get very anxious about prescribing more than 8 milligrams or not basing it on the response of the patient, instead basing it on sort of predetermined levels. Not having the patient participate in the decisions of dosing. This doesn't mean that we turn the whole thing over to the patient and say, what dose do you want to be on? Because we know what would happen there. But it's not engaging them in a discussion about what we expect from Suboxone. What do we expect your symptoms to be? We don't expect people to be totally comfortable, and we don't expect them to be high, right? Which is often what patients are looking for. Punitive response to illicit drug use, so someone relapses and you're out the door. We don't do that with any other disease, right? Diabetic, or I remember when I worked on a cardiology floor, we'd have a guy come in, filled up with fluid to his chest, legs huge, because he, was in heart failure. Get the fluid off, get his blood pressure regulated. Looks like $1 million. A week later, he'd go out, come back in 3 weeks later, looks exactly the same, because he didn't take his meds and he ate food at the cart. That's a New York reference for the food carts, which are not the healthiest. And so when he come on the floor, the reaction wasn't like, oh, this guy, let's see, he doesn't want to change. Let's let him go back out on the street and get, really sick, and then maybe we'll have him back. Or maybe when he agrees to do it, or he gets it. No, you take him back in, you diurese him, you do some more education, you do it again, and he might be back a month later, but that's a chronic disease. That's what happens. And then pharmacotherapy being siloed, so that, I'll talk about this later, but in some of our facilities when I first joined, we had situations where the doc was really not a part of the treatment team. So the medical stuff happened over there, the treatment team happened over here, and never the two shall meet. That doesn't work. If you want to do medication-assisted treatment, that doesn't work. So what helps MAT? You need a role model or a leader who's going to champion it. So you need someone who's going to be a cheerleader. It's not enough to just throw research papers at people and say, read this, doesn't this make sense? That doesn't work. You need to have someone who's really knows the evidence and is able to talk about it also on a clinical level. Making MAT the standard of care in treatment, that's sort of happening broadly, but bringing it into your system and making that the standard by which you measure treatment. And then allowing for different ways of structuring recovery. So 12-step, obviously very important. Smart recovery can be good for people. There's other ways as well. You all are more familiar with these probably than I am. But being flexible about it. This one, hiring counselors with graduate degrees, this is part of a study down here that showed that counselors with graduate degrees are more likely to be willing to use medication-assisted treatment. I wouldn't ever say that people without graduate degrees can't be good addiction counselors, so don't shoot the messenger, this is just a study. And then having connections with research programs, meaning sort of academic-based schools or faculty, can be helpful because then you get that interchange of what's going on in research. They get the feedback of what's going on clinically. So these are some common doubts that I've heard and that sort of been cited in many studies about MAT. One is, and this one I think is getting less and less, the medications don't work. There are at least 8 large-scale reviews of the literature that show the medications are effective, meaning people stay sober longer when they're on these medications. Nobody wants to take them. Well, we know that's not true, although I have heard that before. Their motivation for taking them might be something we don't really like. It's just not true, and adherence is actually pretty good. I was just reading a study the other day about Vermont and how I think the wait list in Vermont to get a buprenorphine provider was something like 9 months, something like that. This is probably more true for naltrexone, especially the oral formulation, but Vivitrol, the injectable naltrexone, does improve compliance. This is another one that costs too much. This is especially true with Vivitrol. If we compare it, the other ones, methadone, oral naltrexone, buprenorphine, and then we compare it to insulin, it's about the same. Now, Vivitrol stands out here, but as more and more, it's becoming standard that insurance companies will pay for Vivitrol, at least to a significant degree. And many of you know that Alkermes also helps out often with copays through their Touchpoints program. So, and we should, again, just note that more than 80% of appropriate diabetic patients are on insulin. Only 15 to 35% of opiate-addicted patients are on MAT. I think these are actually the real barrier to implementation, and this is more philosophical, right? So it's not in keeping with our philosophy. That would be fine if we were talking about theories of mind or Descartes and the cave and what's real and what's not real, but we're talking about a medical illness here, and there is significant scientific evidence that shows that MAT is more effective. So just substituting one addiction for another, this to me is a confusion of what addiction means. Addiction to me carries with it the hallmarks of not being able to function in important roles, holding a job, taking care of family, providing for yourself. It involves increasing doses because of lack of effect, tolerance, and withdrawal. That's not what happens with Suboxone for people who are using it appropriately. Again, there's that 7.5% of people who are using it in the Weiss study not appropriately. And we worry about that. People should try being off all medications first. I don't disagree with this over the long term. I do disagree with it initially. Again, studies like Dr. Weiss's study, clearly show ripping people off buprenorphine or anything else, or just cold turkeying opiates doesn't work. In fact, cold turkeying opiates, the relapse rate is about 98%. So it doesn't work. Even with buprenorphine, as I said, it's 93%. So this is one that I still get from our facilities, something I deal with all the time. If we give it to one patient, they'll all want it. That's not untrue. That is not untrue. So I had one. I can't remember if it was an executive director or one of our docs who said, "Well, we'll just tell the patient they can't talk about their medication with other people." I was like, "Yeah, that'll work really well. I'm sure they'll keep that secret." So look, that's going to happen. I mean, if someone is on Suboxone for a longer term, whether it's maintenance in the sense that they're going to be on it for a year, or whether it's just 12 weeks, that's going to happen. People are going to come to counselors and then, hopefully especially to the docs and say, well, he's on it, so why aren't I? Here's how I handle that, again, in that framework of a chronic illness. There are a lot of different types of diabetics. A lot of different people have high blood pressure. A lot of different asthmatics. They're not all on the same med. There's different indications for different meds based on what the disease is. So just because this person's on one med doesn't mean you should be on it. And it certainly doesn't mean that I'm going to talk to you about why they're on it. I'm going to talk to you about the options for you. And this, I think, is an important part of recovery, is learning to work with a physician, with a treatment team, to come up with a plan that makes sense for you. Not that the patient should have any input into it, but they should be willing to listen to the professional advice that they're paying for, right? And that not everyone's disease is the same. Of course, what this also provides the opportunity for is, why do you want to be on buprenorphine, right? What's the point? What are you hoping will happen if you're on it? And if the answers come back that, with some digging, usually, this doesn't happen right away, I'm scared what life's going to be like off opiates. I don't think I can handle it. What else can I do? How do I manage my life? Well, those are important questions, but those aren't good reasons for being on buprenorphine. This one drives me nuts. I think it's becoming less and less that you're not really in recovery if you're on medication. Again, we don't say that to diabetics who are on insulin, right? They're not really controlling their diabetes if they're on insulin. It's not true. So people who are using Suboxone or naltrexone or Vivitrol appropriately, to me, those people are in recovery. So what are some provider level barriers to MAT implementation? So most of this is lack of education and training. People don't just walk around knowing this stuff, especially in our field. The bias tends to be the other way. And this is all from studies that have shown that this is especially true for addiction counselors, but really that all staff should be given tailored training on MAT. So prescribers should know about benefits and risks of prescribing, because there are both. There's a clinical support system called PCSS MAT, which is designed to provide docs with mentors who have experience using things like buprenorphine and naltrexone, and gives them someone they can call and talk to if they have questions about it. So it's actually a really useful tool. This is a big one for docs, especially, although I think everyone has this concern about misuse and diversion. One of the big things that this particular study down here that you can't see showed that underdosing is a major reason for misuse. So if you give someone Suboxone but you don't give them enough to take care of their symptoms, or you don't educate them about what they can expect on a stable dose of Suboxone, they're more likely to go out and use something to take care of that. So utilizing best practice methods. So this means that you can't, as a doc, I can't just give someone a prescription of buprenorphine and say, see you in a few months. That doesn't work. I need to have that patient in regularly. How regularly depends on their stage of recovery, right? When I do it for patients who just come out, I see them every week. They have to bring in their Suboxone bottle. I count the Suboxone, make sure they're only taking what they should get. They know when they sign a contract, that's another important piece, that says I will not give them more if they run out or lose a pill or the dog eats it. That's the way it goes. And we do urine testing every week, right? So that decreases the likelihood that someone's going to misuse it. Could they still do it? Of course. There's no way of eliminating that completely.